A 45-year-old white male presents to his family physician's office complaining of nighttime heartburn and difficulty swallowing. He points to an area about 2 centimeters above his xiphoid process. The pain is associated with nausea but no vomiting, a feeling of bloating but no real chest pain. The pain is relieved by antacids, and he finds it necessary to use between 2 and 4 tablets of Tums every day to control his symptoms. He hasn't lost any weight and is otherwise active. He has a fairly stressful job as a postal employee. He used to smoke between 1 and 2 packs of cigarettes a day, but he quit about a year ago using Nicorette gum. He drinks, in his own words, about a 6-pack a month. But he only takes Tums and no other prescription medications. His past surgical history was notable for removal of an ingrown toenail 15 years ago, no other operations. An older brother was recently diagnosed with esophageal cancer, and our patient is also worried that he too could have cancer. Our patient is of normal height and weight. He isn't obese. Vital signs are normal. He has no fever. His pulse oximetry is normal. His blood pressure is normal. The head and neck examination is normal. There's no evidence of palpable adenopathy. His lungs are clear. There are no rales, rhonchi, or wheezing. The cardiac examination shows a normal S1 and S2. There are no murmurs. The abdominal examination shows a flat, non-distended abdomen that's soft. There's no abdominal pain. The rectal examination is hemocult positive with a normal sphincter tone. His prostate is smooth without any nodules. Neurologically, he's normal. The cranial nerve assessment is also normal. In summary, this is a 45-year-old male who complains of heartburn and localized dysphagia. What scheme would you start with? And based on knowledge of his history and physical exam, where can we start in that scheme? This is the upper GI series on our patient. It clearly shows a Schatzki's ring. A Schatzki's ring is a result of chronic reflux esophagitis with distal scarring of the esophagus. It also shows the distal esophagus and the diaphragm. After the patient's upper GI series, which showed a Schatzki's ring, he is now scheduled to have a upper endoscopy to rule out carcinoma and to secure our diagnosis of a stricture that is benign versus a stricture caused by cancer. Our first image is of a normal GE junction. The second image shows a Schatzki's ring, as does the third image. However, the last image is placed for comparison. It shows Barrett's esophagitis. Barrett's esophagitis is a premalignant condition. Compare Barrett's esophagitis to the normal GE junction and compare the squamocolumnar junction of the normal esophagus to that of Barrett's. Our patient is a 68-year-old white female who presents to the emergency department complaining of chest pain and difficulty swallowing intermittently for about the past 3 months. The chest pain occurs when she eats or swallows anything and doesn't seem to be related to the temperature of the food that she eats. She's not able to tell us exactly where the pain is other than saying, quote, "My entire chest hurts." When she first complained of these symptoms, she saw her family physician. He performed an EKG, and according to the patient, it was normal. She doesn't smoke and never has. She's never used any other tobacco products. She was also recently evaluated for this chest pain by her cardiologist. Her cardiolite stress test was normal. She even had a coronary angiogram because of the fear of a possible false negative result. Her angiogram, which she reports to you, was also normal. She's never traveled out of the continental United States. Her medical and surgical history is notable for a cholecystectomy about 5 years ago, and she had a colonoscopy 8 years ago, which she says was, quote, normal, end quote. Her current medications, she has no known drug allergies. She does have high cholesterol and hypertension, and she takes a daily aspirin. She takes atenolol, 10 milligrams a day for hypertension, and Lipitor, 25 milligrams every day for her high cholesterol. Based on the patient's symptoms, her previous medical workup, and surgical history, which scheme would you choose to begin with? Our patient is awake, alert, oriented, in no distress. Her blood pressure, pulse, temperature are all normal. Her respiratory rate is normal. And her pulse oximetry on room air is about 93%. She seems comfortable and she is not clutching her chest. She's not coughing and she's not complaining of any jaw or left arm pain. Her pupils are equal in size, reactive to light. Her chest is clear to auscultation. She has no heart murmurs, and her cardiac rhythm is normal, and there is no ectopy. She has no cervical adenopathy of her neck or of her axilla. The trachea is not shifted, and her thyroid gland is non-palpable. The abdominal examination is soft, non-tender, non-distended, with normal bowel tones. She has scars from her prior cholecystectomy. A very brief neurological examination shows the patient's cranial nerves to be intact. Her strength is equal and symmetric. She has no rashes. Rectal examination was not repeated because it was performed recently in the family physician's office about a month ago and was hemoccult negative. The patient denies a history of seizure, stroke, weight changes, fevers, chills. She further denies a history of nausea, vomiting, or a history of a myocardial infarction. She denies a history of diabetes, hepatitis, bright red blood per rectum, dysuria, frequency, hesitancy, or chills. She does admit to having hypertension and high cholesterol, for which she takes medications. And she does admit to chest pain, as described above, but she has no known history of a hiatal hernia.